Welcome to Season 3 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call. Today, Stephanie Desmond talks to Dr. Paul Spiegel, who directs the Johns Hopkins Center for Humanitarian Health, about how the COVID-19 pandemic has impacted refugees and others in conflict zones and what lessons have been learned. Let's listen. Paul Spiegel, thanks so much for joining me.
It's a pleasure, Stephanie.
Today, I'd like to talk to you about the impact of the COVID-19 pandemic on refugees and people who live in conflict zones. Can you give an overview of how this has impacted those folks?
Certainly. The short and sweet answer is that we sadly do not have enough good quality data to have a comprehensive or quality answer. But I can say at the beginning, we had expected that there would be a significant amount of transmission, particularly in camp-like settings where there's a high population density. So we expected a lot of transmission and consequently high hospitalization and bed occupancy rates and high death rates. Although we did recognize that given the demographics of the population, they're in refugee or IDP, internally displaced person settings, there's a very young population. So we knew proportionally that the deaths would not be as high as in China or the US or Europe. But we did expect that. And what has been reported, though, has not actually borne out those data at this point.
You sound a little bit like you doubt that data.
Yes, I think the data certainly at this point is biased because at the beginning there weren't enough tests. So we saw a very high positivity rate, but it was because they were really testing those that were quite sick. And over time, in some settings, the testing has improved, but unfortunately, the data are sparse. There's a problem with data sharing widely and with academics. And part of the reason is that there's a lot of stigma and discrimination against these groups. So those that may have some data, understandably, want to make sure that the data will not be used to further stigmatize these groups. But conversely, unlike in other settings, there have been very few seroprevalence studies, so antibody studies, to know how widespread the transmission has been. And then finally, just to say that we have not seen, at least reported, in many refugee settings and in many refugee camps, there have not been a significant amount of deaths reported. The question is, are we missing them or are they actually not happening?
How can a lack of data hurt people?
Lack of data can hurt people and responders dramatically, because if we don't understand what is happening, it is very difficult to plan, it's very difficult to prepare, and it's difficult to modify the interventions, whether they be the non-pharmaceutical, meaning physical distancing, hand washing, or in this case, vaccinations. So it's just like you're shooting in the dark when you don't have sufficient data.
Mm-hmm. I'm glad you brought up vaccination because I know that there are shortages of vaccine at the moment all around the world. I can't imagine these groups are high on anyone's list. Can you talk me through that?
Yes. This is something early on that we wanted to flag, and not just for refugees, but for non-nationals. So even here in the United States, there are many undocumented migrants. And I think the argument can be twofold. One is a human rights and equity argument, but there's also supporting this is a public health argument. And in many settings, whether there are refugees or undocumented migrants, in some settings, they may make up a significant amount of the population. And therefore, if they are not vaccinated and included in a vaccination program, transmission can occur, variants can occur. So from a public health point of view, it makes sense not to think about someone's status, but just to think about their age, their comorbidities, and follow the same rules that would be happening amongst nationals. Overall, this has not been happening yet, but I must say there are some countries like Jordan that have been very generous with a limited amount of vaccines, have also started to vaccinate refugees.
It's not politically popular, I imagine, to give your vaccine to refugees.
Exactly. I think that's another big issue, which I think more and more we have to understand and perhaps not accept, but as public health people, it's our job to provide the evidence and our recommendations. But politicians do have to take into account they have to take into account into the evidence, but they have to take into account some self-serving in terms of their political careers. But more importantly, I think what we've seen in terms of the populism, in terms of the anti-refugee and anti-migrant population, they have to think about that as well. And so there can be a boomerang effect if, as we're even seeing on the southern border now with the Biden administration, where they're trying to be more humane and allow people to come in, or at least unaccompanied children, there can be some negative effects.
And I actually just interviewed Chris Byrer recently, and we talked about vaccinating in prisons and jails and detention centers, which I think is also in the same way politically unpopular. Absolutely.
So yes, it's very politically unpopular, but necessary. And an analogy that I've used a lot has been antiretroviral therapy for HIV, patients with HIV and AIDS. Early on, it was very unpopular to provide to non-nationals, whether they be refugees or even nationals, IDPs. It would go to there was so little antiretroviral therapy. But over time, and as vaccines will become more available over time, I think it will be more palatable to, I hope, to the citizens and to the governments to be able to then expand to these groups. But again, from a public health point of view, that may be detrimental to everyone if they wait too long.
I know something you're passionate is about humanitarian efforts in general. And I'm curious how COVID could be a catalyst for some transformation in these efforts. How is giving aid to folks in these places, how has that changed during COVID? And how do you think it may be changing going forward?
It's been interesting to observe in a pandemic how humanitarian assistance and how international assistance in particular has changed compared to Ebola, where Ebola in West Africa and then in DRC, you had a massive amount of funding coming from primarily Western governments, and you had a huge surge of international and national, but international expats coming in. And that's because there were no travel restrictions at that time. Ebola wasn't, like COVID, affecting their own populations. So given now with the pandemic, with the lack of travel, but also people being concerned about their own safety, and there have not been the same amount of response that one would see normally to a more circumscribed epidemic. Although we don't have sufficient data to really understand at this point how COVID has affected many of these populations, we have seen that governments and national NGOs have done their best to step up. And we have also seen the way telemedicine and other ways of providing aid may occur due to this pandemic. So I'm hopeful, although we shall see. I think it will be ultimately up to donors, but I'm hopeful that the COVID pandemic can be used as a transition or even a impetus for what we call localization, which means providing governments and providing national NGOs the funding and more capacity to respond than the international community. That won't be the case immediately, but I'm hoping this can be an impetus for that to occur. One of many things that I think we'll learn from COVID and the pandemic.
What are some of the other lessons that you see in the humanitarian field?
I think that the funding can and will change. I mean, what we're seeing now is a lot of funding from multilateral donors and from bilateral, the wealthy countries. The predominant amount goes to the UN agencies, the United Nations agencies, and to international NGOs. I think that we've been able to show over time before COVID and certainly during COVID that governments in these countries have more capacity than we gave them credit for, and similarly the national NGOs as well. And so I'm hoping that besides just talking, we can actually, more funding can go towards to those populations and through these different organizations, which will mean that ultimately the UN and the international NGOs may need to rethink both their business model and the way that they provide assistance. There's always going to be, I don't want to say, and I don't mean to say that there's no need for the UN and international NGOs. There will always be in terms of capacity, but also in many situations when governments are repressing their own people, you need these sort of groups to be able to come in. But I think that I'm hoping that there will be at least a change in the way of thinking, and where will international NGOs and the UN be 10 or 20 years from now as governments and national NGOs become more capacitated? In my view, I think that's going to be likely a reduction in their funding, in their numbers of staffing, and possibly their presence. And then they will have to find a niche, a different niche than they're filling at this point.
Because the attitude really has been very paternalistic, right? That these countries can't take care of themselves, they can't deal with their own crises, so we must send in money and people to basically flood the zone to fix this. And that wasn't available this time.
I don't know. I'm hopeful that there will be a shift, but I don't see a shift now. And what I've also observed over time, working with the UN and working with NGOs, is that, and even just working here at Hopkins and in academic institutions, is that it's not easy for organizations to say, okay, we are prepared to receive less money, to hire fewer people, and to have less influence. So it has to come from some sort of external push or external stimulus. And here, I think that would be the donors. But are the donors ready, who are primarily Western donors? So number one is, will there be other donors that are coming from other, let's say, non-Western or other high-income countries willing to step in and provide more money? But then number two, are they prepared to provide money to governments and national NGOs that may not have, at this point, due to capacity, the same standards? There may be transparency, corruption issues, and they may not yet have the capacity to provide the rigorous financial reporting that is required and that most of these international institutions have and the national capacities, national organizations do not yet have.
Well, it will be interesting to see how this plays out post-COVID. Paul Spiegel, thank you so much for joining me.
Thank you, Stephanie. It was a pleasure.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, C.N. Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.